Hi, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today to discuss the common conditions and skill set required to serve as an overnight summer camp doctor are Dr. Peter Antevy, a pediatric emergency physician and medical director at Coral Springs-Parkland Fire Department in Palm Beach County, Florida. Also joining me is Dr. Matt Harris, a pediatric emergency physician with Northwell Health. Welcome to both of you. One of the great summertime adventures of so many children and teens is going to summer camp. Both of you have clearly served as camp physicians, and I want to get into sort of the mechanics of what it requires, because many people think any kind of physician can do this, but really it's not. So Pete, let me start with you, and tell me about your experience. How long have you been doing it? What are the common conditions you've seen over the number of years you've been serving as a camp physician?
Yeah, thanks, Rob. I grew up, my parents couldn't afford camp, so this is kind of nice for me to go and be a camp doctor. It is a sleepaway camp. It's up in the Northeast. I've been doing it for 8 years, and I have 3 boys who have gone through the camp, and one of them is still a camper, so I still have a few years left. The camp has about 400 children, and then there's about 200 to 250 staff. So you're dealing with a lot of people. How typically it works is that there's one doctor per week, and that's how they can get doctors to come in and cover the entire camp season, which oftentimes lasts 8 weeks. So they have to get 8 different doctors. Type of things that we see, and it's as if you were working, let's say, in a pediatric urgent care. You see a lot of trauma, right? We have skate park, and we have basketball, and we have swimming, and we have the speck on the lake where they're jumping on and off. There's small crafts, there's skiing, there's wakeboarding. So you can imagine that there's typical head injuries, concussions, a lot of lacerations, abrasions. Kids have lost their teeth because things have hit them in the mouth. Lots and lots of rashes. And then almost every year, because you have kids coming from across the world, right? A lot of these counselors are coming from Australia and the UK. Invariably, people are bringing in their illnesses. And every year, that illness just spreads through camp. So for weeks, it seems, you're dealing with cough and cold and flu. It just seems like at the clinic is a rotating door of kids coming in and out, and it's very busy. I'd love to hear what Matt has to say as well about that.
Matt, please go ahead. I'd love to hear your experience as well.
Yeah, I think I'd echo a lot of what Pete said. I think that a great deal of this, I think, can be sort of mom and dad care, right? So we always tell the counselors before you come to the clinic, what would you be doing at home, right, with this kid? So there's a lot of cuts and scrapes, a lot of runny nose and coughs, and early in the summer, a lot of allergic symptoms. So, kids coming up to the country after living in the city all year. And so, it's a great opportunity to think about your differential for cough, right? Is this infectious? Is this allergic? Is this just, I think we have this sort of term at camp, sort of camp crud. Something's always kind of running around camp. I think what Pete hit on is some of the really interesting challenges is that, these are the same things that walk into urgent care or the pediatric emergency department, and you don't have the full arsenal of tools you would otherwise have. And you certainly don't want to start sending kids unnecessarily out of camp for care. And not just because they're going to miss camp, but because it's really, really hard to find the high quality care that you want. Many of these camps are in really remote environments. So the access to pediatric subspecialty services or even pediatric ERs is really hard. So I think one of the wonderful challenges actually is sort of using your clinical intuition and a lot of the rules that it seems so academic to us in training about concussions or how to decide who needs an ankle x-ray. You really get to practice these in real time. So actually I felt this is a really wonderful academic opportunity to use a lot of this information that, maybe perhaps falls to the wayside when you have all the tools of the typical emergency department or urgent care at your disposal.
So let me ask both of you, what do you keep? What kind of instruments? What's your toolkit look like? How is it set up?
Yeah, sure. I'll start. So obviously, everyone's got a stethoscope and an otoscope and a flashlight. Those are the important ones. So we have the big cabinet of every OTC med, and then all the creams that you would need for all these rashes, and then there's kind of the trauma section, if you will, all the bandages, the co-bands, the splints, etc. In the past couple of years, based on some things that I've experienced and based on some stories that you hear at other camps, I actually loaded up with some more higher end things. So, IV fluids, some airway adjuncts, airway supplies that just in case, because you do hear about those kids who have drowning issues at some of these camps, and you always want to be prepared for that. Especially like Matt alluded to, we're pretty remote. So even if I call 911, which I have on certain occasions, because of where we're located, they're not going to come for maybe 15, 20 minutes, and then it's a BLS crew, and then the ALS medic comes 30 minutes after that. So I decided to go a little higher. I actually do have all the suturing equipment. I brought that with me as well. There are kids who get, eye issues, and so you want to have the fluorescein. You want to be able to check for any corneal abrasions. And then the prescription med cabinet, if you will, is highly used, so that if I'm going to start somebody on antibiotics for strep throat or what have you, I have that first dose ready. I'm also carrying Zofran. I have lots of steroids on board in case I need to use those, and I did quite a bit, a lot of allergies like Matt had mentioned. So you really have to have a nice complement of that. The camp that I specifically work for has it very well staffed, so that I have nurses who are just incredible, and I'm there just to help the overall camp see that many patients each and every day.
I think you're going to find that our camp is pretty similar in how we stock things, as Dr. Antevy was saying. I think one of the things to consider is that while we bring a lot of this to camp, we have to match the resources to the skill set of the pediatricians and other physicians who are coming. So we have suture equipment, we have things to help with orthopedic injuries, but the reality is that we have a wide variety of the types of physicians who come to camp. Many of whom have been the camp physician for many years and are quite talented. But we have pediatricians and adult emergency medicine physicians, a PEM physician. We also have some internists. There is a family medicine physician doing this for many years, but that skill set is somewhat different. So I think one of the interesting challenges is how do we decide what the sort of par level of care can and should be? And I think part of that is the comfort level. But I think Pete brought up a really important point. We had a story not from our camp, thank goodness, but from a camp farther upstate that had a young man with commotion cordis, was struck in the chest and went into cardiac arrest. And it really was the fact that they had multiple AEDs on camp, that they had multiple go bags with sort of first line medications and airway equipment. And that child is alive and well today. So I think those are the never events, right? I mean, 99% of what we see is rashes and URI symptoms and coughs and scrapes. And you need an x-ray, you don't need an x-ray. But I think one of the things I've really enjoyed this summer is helping build the capacity at our camp to respond to those very, very few emergencies. And like Pete, we called 911, I think 3 times over the summer. One was for pretty significant sepsis and hypotension, which thank goodness we had IV fluids because, it was 35 minutes before EMS got there. So I think we are bound to think about what is common and then really responsible for what is that 1 out of the 600 people that we care for over the course of the summer between staff and campers that could have that life-threatening emergency, anaphylaxis, significant trauma, drowning, and so forth. So, yeah, I think we're very much in lockstep.
And in terms of airway equipment, do you keep a glide scope available, intubation medications, all the standard kind of?
Yeah, I think what we decided to do, and I think just again recognizing that the skill set is variable amongst our providers. One of the things that may be a tangent to this is everyone has to have a recent pediatric advanced life support certificate. Now, there are many in our field in emergency medicine and pediatric critical care who I think recognize that these are often somewhat considered like a merit badge course. But I think that for the general pediatrician who maybe hasn't been part of a resuscitation in many years, or the family medicine doc, or even frankly our emergency medicine colleagues who are increasingly becoming more subspecialized into the adult world unless they work in the community, having that skill set and refreshing is important. So we had bag valve masks around the camp. In the clinic, we brought supraglottic devices because I think there's a strong amount of evidence. And Pete and I both work in the EMS world, and I think both of us recognize that the first pass success rates, even for a novice user for a supraglottic device, is much higher than any attempted intubation. So I think, knock on wood here, we did not have to use any of it, but it's there. And I think one of the other things I'll mention is that we are talking about some degree of simulation next summer. So not the high fidelity computer feedback, but bringing some old-fashioned dummies to camp and running a simulation down by the waterfront, going to the ropes course, and walking through what's common: anaphylaxis, drowning, head trauma. And so I think that equipment should match our needs as well.
I would say that at a baseline, there should be a go bag. And whoever's working, whether you're a GI doctor or a pediatrician, internist, etc., you ought to know every piece of equipment's in that go bag, and you should probably know how to use it. And I would always recommend coming in a little early to the camp if it's your first time there, meeting the people, understanding what their skill sets are. And then, like Matt said, going and doing some sort of simulation. It doesn't have to be high fidelity simulation. And then I make it a point of speaking to every single counselor. We put them all into a room and we go over some of the basics. We haven't discussed this yet, but many of these kids have their own medications. Many of them carry EpiPens. There are now a lot of intranasal seizure medications, Valtoco, and these kids have these bags, and we coach them to put their rescue med, whether it be, like, for example, I have a child who's diabetic and he has his Baqsimi, and everyone knows that that child exists, what their issue is, and where to find their rescue medication. So there's some basic things that could be done. We have the supraglottics, but I have all the video, laryngoscopy, the disposable ones. I just carry that with me, but I'm kind of more of the only person probably who does that in the camp that I go to. But these are never events until it happens to you. And that's why I think that we ought to take these types of things seriously as the physician managing this number of people.
Yeah, I think, if I may, I think one of the things also to keep in mind are 2 points, and they're somewhat in different directions. The first of which also is leveraging the fact that there are other people in camp who have some degree of experience as well. So all the lifeguards are CPR certified. So developing a mechanism that if somebody goes down in camp somewhere, that I might be a mile away at the clinic, but the lifeguards are pretty darn close. All of the ropes course people are trained in CPR and first aid as well. On a more benign course, I think one of the things we decided this summer, which they hadn't done in a while, is how do we reduce the number of kids who come to the clinic for sort of bumps and scrapes and things that don't really need to be seen? Because again, the clinic is a place where people are coughing and have fever. So we started putting simple things like calamine lotion in the bunk. I can't tell you how many kids come to the clinic and we have to write a full chart note just to put some calamine lotion on. Some bacitracin, some Band-Aids. So we don't want anyone certainly sitting there giving themselves home meds. But I think there's also a recognition that these things are okay. And we also worked with the camp really closely. We were seeing tons of kids for dehydration. It was really, really hot. So we bought some fans for the camp with misters, kind of like on the side of the football field. We put Gatorade and ice packs around camp in different places. So I think on the less malignant side of the world, rather, I think helping keep kids in camp and away from the clinic, I think, is just as important as the conversation of reducing unnecessary ED to ED transfers, right? Trying to keep kids back where they're supposed to be.
I think with climate change and heat-related illness increasing, parents are concerned, obviously, and taking breaks and certainly hydration. Have either of you had any significant, heat-related illnesses come up that you had to transfer a patient?
Yeah, I was just going to say, we haven't really had that issue, but on the very hot days, I think the camp does a wonderful job of really pushing fluids. If you don't have a water bottle, they say, "Hey, where's your water bottle?" It's a very big thing on our camp. So thankfully, knock knock, we haven't had an issue with that.
Yeah, I'd agree. I mean, I think we certainly had days where our resting room, which is a room in the clinic that does not allow febrile patients into it, we definitely filled up. I think until we discussed some of those mitigation strategies with camp, and the camp, I think, was really quite responsive to getting things out quicker. Water bottles, Gatorade around camp, ice packs, misters. So I agree. Yeah, it wasn't an issue, but I also think it's something we're going to pay increasing attention to.
How about in terms of infectious disease outbreaks? Have either of you had any infectious disease issues that you've had to kind of scale up in terms of getting additional help or transferring children out?
Yeah, so with us, it's been strep. It's common, right? So once that first strep comes in, you'll tend to see it continue. So what we do, we isolate the child for at least 24 hours. We start them antibiotics, etc. The other common one is MRSA. And so once you see some kids with MRSA, you see a lot of kids with MRSA. So the camp has done a great job this year of starting a towel service where they used to have the kids bring their own towels. And once I got rid of that, this past year was much reduced. And then the last one is when we had COVID, we're talking about the height of COVID. One year camp was shut down, but when we came back the following year, everyone was still concerned about it. We actually had all the testing capabilities, and we would test people before they even arrived into the camp. So, whoever's out there listening, you have to be able to scale up if you know that there's an issue, and you also have to be scale up if you're at the camp and something happens unexpectedly during that camp. You have to have some mitigation strategies, at least somewhat plan ahead of what you're going to do, where you're going to put some kids if you have to isolate them, or send them home completely from the camp, which we have done in the past.
Right. Yeah, I think certainly this summer has been challenging with COVID spreading throughout the country. Did either of you have any issues in that capacity? Matt, I'll let you go.
Yeah, so I think that, testing is really an interesting question at camp because, I think most of us know that the majority of viruses that go around, are clearly communicable, but also relatively benign. Fever and cough for a couple of days. There's lots of enterovirus and stuff during the summer. Similar to Pete, we will isolate people until they are fever-free for 24 hours. But it's sort of a rule of thumb. If you're febrile for more than 3 days, you're going home. Because I think that at that point, we want to really minimize the impact both on the campers in their bunk. It's also pretty miserable to be in the clinic, even though it's air conditioned, which all the kids love, and we have TV for them to watch. It's not how they want to spend their summer. So often, if it's feasible, after 3 days, they go home. Now, I will say that our camp, like many camps in our region, actually had an outbreak of pertussis towards the end of the summer, which is not something that I think we had thought about ahead of time, though I think Pete's point is important that we had discussed ahead of time mitigation strategies for COVID. So the infrastructure and some of that muscle memory was there. But I do think it's an important opportunity for us as camp physicians and camp physician leaders to think about what are our reporting responsibilities? How do we leverage testing that's not traditional, like COVID or flu? How do you partner with local pharmacies, especially near us, where there's only 2 or 3 pharmacies in the area, if you need to have, and for even more benign things, like we had an outbreak of impetigo almost every year, where it just spreads through the bunk like wildfire. So I think that it was certainly an interesting part of our camp, and we were proud to say that we were able to successfully mitigate it. And we know of several other camps in the area that really have large numbers of kids. And I should say that our camp, and this is, I think a decision made by leadership, is you must be fully vaccinated to come to camp. I think there are some discussions about COVID, but all other vaccines are mandatory. And if you're not vaccinated, I think, we come up with recommendations for your camper for an alternative location for the summer. But yeah, I will say that this was an interesting, unexpected challenge, but because we had talked about mitigation strategies ahead of time, it was something we were able to do. It took some time to stand up, but we were able to do it.
So moving on a little bit in terms of mental health, that certainly is at the forefront of many parents' concern, and the campers for that matter. Many are taking medications, psychiatric medicines that are affected by the heat, obviously, but also stimulants and so forth. What are your procedures and protocols in each camp that you're with? And Pete, I'll start with you.
Yeah, this is a fascinating topic. It just seems to me that the kids every single year are having a tougher time from an emotional well-being perspective. So much so that, the camp I'm at has done a fantastic job of having someone on the boy side and on the girl side who really focuses specifically on those kids who may need more help, especially in the beginning. Obviously, the first couple of days, the first week are tough for some children. Rob, like you mentioned, there's a lot of children who are on anti-anxiety meds and meds, etc. It is something that if you're not attuned to it, if the camp doesn't understand how to deal with it, or if they don't have the right people stationed across the camp, because oftentimes it's not the doctor, it's not the nurse. We're more acute medicine type focus. There has to be people across the camp who are very in tune with these children, and you almost have to know that individual item about that kid. And over the years, what's nice is that these kids, and if the camp is very sturdy in their staff, and the staff comes back year after year, you find the transition from week 1 into week 2 until you're finally home free to be much smoother.
Yeah, and I'll add to that I think our camp has a very strong what's called camper care group, and this actually includes a couple of psychologists because I think we know that the incidence of behavioral health disorders is increasing in both our our campers and our counselors, and their care needs to continue, especially what could be a big stressor for them leaving their home environments for 2 months, right? And the stresses of camp. I mean, we see the same type of stressors we see in schools, right? Not all the campers always get along. Maybe there's some bullying or something you don't get along with, some degree of embarrassment. So I think, these are common things for adolescents and younger kids to deal with every day, but now they don't have their parents, they don't have their home environment. I think one of the nice things is that, one of the more ubiquitously used electronic records, something called CampMinder. I think Dr. Antevy's camp uses that as well. And one of the nice things about this, and I certainly have no stake in the CampMinder business, is that you can see the notes from the other parts of camp, right? So that while our medical notes are protected for HIPAA reasons, the physicians can see the camper care notes. So that way, if there's a concern. And I'll also say that what's been nice is the collaboration. I imagine this happens at Dr. Antevy's camp as well, that, we met weekly with the camper care group. Who were you worried about? We would bring some campers to them and say, you know what, we've seen so-and-so every day for the past 7 days, and they've had a very reassuring exam. We've spoken to the parents. Maybe it's time to think if this is something less organic and something that needs to be dealt with on more of a psychosocial level. So for the more benign things like I miss mom and dad to, hey, I'm struggling because I'm on a new medication and I don't like how it makes me feel. And so I think that the collaboration between these groups, just like in our other clinical settings, is really important.
I had mentioned earlier that there's a lot of staff that are not US based, right? They come from the UK, they come from Australia. And they're very far from home. And I think they're a little bit more resilient type of, they're older and so forth. However, what I've recognized about them is that they are very lacking in their healthcare, either because of the system in their home country or what have you. So I find myself dealing with a whole bunch of chronic issues that really bother these kids. I had one kid whose ACL had ruptured a year and a half ago. And I said, why haven't you gotten that fixed yet? He said, I'm waiting in line. And so these kids, from a mental health and well-being perspective, a lot of them come to America because they think that they're going to get, healthcare here, and they do lean on us at the camp. And we often find ourselves referring them to people outside the camp with their overseas insurance. So when you're in camp, it's this very interesting thing where you have one kid who's from, let's say, a very affluent part of the world who's got everything. And then you have another staff member working right alongside them who hasn't gotten good care for quite a long time, especially something that they really needed to be taken care of. It's a fascinating view of the world from a healthcare perspective coming to a sleepaway camp.
I'm not clear about what the policy is at your camps regarding social media, having the phone. Is it always accessible to a camper, or is it, in other words, are there hours when they can use it, sort of restricted? And how is this affecting their ability to integrate, make friends in terms of their mental health?
Yeah, Rob, this is a great question. Our camp has a no phone policy. So as soon as you get to the camp, if you have a phone, you put it in a bag and they take it from you until you leave. What's very interesting, though, and I alluded to it with the whole mental health issue, is that a lot of these kids now, and again, I have 3 kids, and I'm not saying that we do everything perfectly by any stretch of the imagination, but if you're leaning on social media all the time, or if you're disconnected from other children, what we see a big issue is that when these kids now come to a camp, they're in a bunk with, let's say, 15, 16 other children, and something happens between the 2 campers, those coping skills are not like they used to be. They are not able to just go into their room, close the door, open TikTok, and start doom scrolling. They can't do that. So what we see is a lot of children who have anxiety, who have depression, and they don't have the coping skills to enable them. And so, like Matt had mentioned, and I love the concept of him, they have psychologists there. What our folks end up doing is educating these kids on how to behave with other human beings. And that's a big, big part of the greatness of camp, is that we're doing for them what they can't do at home because of the society and the social media world that we live in. So it's a great question, and I think it's a fascinating topic.
And Matt, what is your experience in terms of managing campers in terms of what Peter's describing? Is it similar in your fashion?
So similar at our camp, there are no phones allowed at camp. There are some exceptions when our campers go on, some of our older campers will go on a 2 or 3 day trip to some other large city in the area, in which case they can have their phones back just for safety reasons. But as a rule of thumb in camp, there are no phones. So, what's an interesting phenomenon is that when I was a camper many, many years ago, I'd write a letter. 2 weeks later, I get a letter back from a friend or a family member, but now they can email their letters. And so there's some unidirectional information. So I'll sometimes get a call from a parent saying, I just heard from my son about, or my daughter about X, Y, and Z. And I go, oh, they got an email. Until I got my first email from my children, I was a little confused about that. But I think it's important. I think it's important to have time away from their phones. I think, and we are guilty as charged in my house too. I think we're somewhat dependent on our phones. But I think, honestly, I think the other part, which just being somewhat greedy about this, is that I also wasn't on my phone. It's kind of a nice break. There's no TV at camp, right? So it was a night. I found myself doing the work I need to do in the clinic, and then reading outside on the porch, or catching up with some work, or going for a run around camp and shooting some hoops with my kids. So I think camp was actually a great opportunity to sort of divest away from the world of social media, both for the campers, the counselors, and for me.
If either of you have a couple pearls to take away for our audience, would love that. Peter, I'll start with you.
Yeah, I think the biggest pro for me is that is the interface with the parent when something goes wrong. And I think that's a skill set that I think most clinicians should have. But when the child comes in, what I love is that they handle themselves beautifully. They could be 6, 7 years old. They're amazing. Then you pick up the phone to the family member, and you never know what you're going to get on the other line. And that's understandable because their child could be across the world. We have kids coming from Spain and Dominican Republic, and then they're getting the doctor on the call. So I think that you should probably learn the typical way of how to call, ease the parent's fear, because it could be something minor like a little scratch, and they hear a doctor and they have a heart attack. So I think those little nuances, and then working with camp administrators that are just very good and understand what good healthcare is always a bonus.
Absolutely. And Matt?
Yeah, I'm going to echo what Peter said. I think communication in many respects is super important. And I think also expectation setting for the campers, right? For the counselors, for parents, about, what we're going to call for and what we're not going to call for, right? Because I think that we want to make sure that parents know that we hope that we have set up a medical system at camp that inspires confidence that their children are well taken care of, both in terms of their daily medications. Many kids are on injectable medications for growth hormone and other things. So we want them to know that they're getting their routine medications, they're getting their care. And when we call you, we're going to call you and be good communicators, but you're not going to hear about every, scratch and rash. But Pete really hit the nail on the head. And I always sort of joke, every time I call, they say, "Hey, it's Dr. Harris. Everything is okay," right? Except for maybe the 1 or 2 cases where it wasn't so okay. And I think as an ER doc, we're used to making these phone calls, right, Pete and I. The parents who really had some of the more challenging medical experiences with their campers, we're so thankful for that. And actually, I think that it's not how frequently you communicate, but how effectively you communicate. So sometimes you have to read the room a little bit, and some parents don't want 6 phone calls with updates, and some parents need to know they're also not going to get 6 phone calls with updates. So let's set expectations up front at the beginning of the summer, and let's harness that hopefully very robust relationship they already have with the camp to build confidence in the medical system that we've developed to keep their campers safe.
I want to thank you both for your service to taking care of campers, obviously counselors and parents, because it's all a community. And again, thank you for your time. Our audience will truly appreciate your pearls.